ان شاء الله الجلسه بتاع ريسبيراتوري سوسايتي اوف صربيا الاساتذه الاستاذه الدكتوره آية عبد الدايم، الاستاذه الدكتوره جيهان عسال، الاستاذه الدكتوره ليلى عاشور، الاستاذه الدكتوره ريفين، الاستاذ الدكتور رأفت، الاستاذ الدكتور تامر.
Thank you. They will introduce you. Okay.
Good morning everybody. السلام عليكم ورحمة الله وبركاته. Welcome to our club. مرحبا بكم في مؤتمر الجمعية المصرية للشعب الهوائية. Welcome to Egypt. First of all, we are very happy to receive you here in Egypt. I hope you enjoyed the previous 2 days. And this is going to be a very nice presentation from Serbia. This session about Respiratory Society of Serbia. The first is sarcoidosis in Serbia, an overview by Dr. Violet Vucini. This is right? Yes, please, welcome.
Excellent.
Excellent. Thank you very much. We are very happy here to receive you here in Egypt. This is your first time to come to Egypt?
Oh, yes, it is.
Oh, welcome, welcome, welcome. We are so welcome for Serbia. Thank you very much. Please introduce your lecture. Thank you.
Thank you. I also let me speak on behalf of my colleagues from the Respiratory Society of Serbia, and personally, I really appreciate your hospitality, and I appreciate especially Dr. Gamel and Dr. Tariq, who invited us and giving us a chance to speak about the pathology, respiratory pathology in Serbia. You think so? This is the University Clinic of Pulmonary Diseases in Belgrade, and however, the clinic is a part of a worldwide group of sarcoidosis, Warsaw Sarcoidosis Clinic, and we do a lot of research and, of course, first of all, diagnostics in our sarcoidosis patients. You will see that later on. This is our sarcoidosis team. Some of the persons you probably recognize. We organize a lot, quite a lot of continual medical educations in the past years, and I was really lucky that a part of my lifetime and work time I was cooperating with the late Dr. Om Sharma, the President Emeritus of the Respiratory Society of Serbia, publishing these 2 books. Sarcoidosis, as you know, is a multisystem granulomatous disease of unknown etiology and unpredictable course, and it is characterized pathologically by the presence of non-causating granulomas. And the presenting features are protein ranging from asymptomatic but abnormal findings on chest radiography up to progressive multi-organ failure. And this is how it may look. Sarcoidosis Research Foundation took snowflake as a symbol of sarcoidosis because there are no two of a kind. Each patient has his own story, and it's completely different one from another. They are different. How we secure the diagnosis? We make the compatible clinical and radiographic findings. We exclude other diseases that may present similarly, and of course we do the biopsy and try to detect non-causating granuloma like this one. There are data from the literature that there are some exceptions to the need for a biopsy. For example, if we have asymptomatic patient, stage 1 of the lung disease, with representing with classical Löfgren syndrome, like fever, erythema nodosum, bilateral hilar lymphadenopathy, arthritis. However, if you look at our experience on 2,000 patients, almost 40% of our patients did start with acute beginning, meaning erythema nodosum, Löfgren syndrome, and so on. But later on, during follow-up, there is a chronic course of this unpredictable disease. And so if we want to treat them with other treatment than steroid, then we have to secure the biopsy and the proper diagnosis. Certain manifestations are highly supportive, like lupus pernio, this in the middle erythema nodosum or Herford syndrome. And the first observations and the first description of sarcoidosis was done by Jonathan Hutchinson in this female patient, Lady Mortimer. Since that time, female patients outnumber the male patients, and we have 2 times more female sarcoidosis than male. Speaking about the symptoms in our sarcoidosis population, most of them complain. These are the data from the thesis of Dr. Popovich on sarcoidosis. Most of the patients complained for cough. Cough is commonly reported in sarcoidosis patients, and it really reduced health-related quality of life. The mechanism is not completely known, and it was a recent publication 2 years ago from authors who find out that no association between cough frequency, lung function, number of organs involved, or chest radiograph, or serum angiotensin converting enzyme levels, no correlation between those parameters. Fatigue is also a very serious problem in sarcoidosis patients. In our recently published data, in our sarcoidosis group, almost 400 patients declared fatigue. Speaking about immunology in sarcoidosis, the disease causes a complex combination of immune networks. We also have involved immune paradox with hyperactive immune system at the site of granuloma and peripheral energy in the blood. There was a meta-analysis indicated that probably butyrophilin-like 2 gene polymorphism may increase the susceptibility for sarcoidosis, and we did the analysis in our sarcoidosis group, 86 patients, 79 controls. However, we found no statistical significance between the distribution of BT and L2 genotype in sarcoidosis and healthy controls, different genetic models. You see dominant, recessive, and homozygote model. What we do to secure the diagnosis, we do the biopsy, we perform bronchoscopy. You probably, a lot of you know Dr. Spasar Popovic, who is our distinguished broncologist, and do all the diagnostic procedures in sarcoidosis. These are our bronchoscopic findings out of this 571 patient. We found that extramural compression, very frequent, significantly, highly significant correlation between endoscopic findings and radiographic stage of sarcoidosis. And unfortunately, we don't have patients in stage 4 of the lung disease, and we wonder if the endoscopic findings could present the prognostic factor, as a matter of fact, in our sarcoidosis patients. These are the biopsy results. Forceps biopsy positive in 2/3 cases, stage 1, 50% of patients stage 2. Of course, yield decreases in stage 3, and unfortunately only one, or fortunately, because this is very difficult, pulmonary form of sarcoidosis stage 4. Biomarkers, we use AC as the commonest ones, despite the sensitivity and specificity which are very low. And serum ketotriasidase we also use in investigating the disease activity. There is a publication from Serbia. We analyzed the activity of serum ACE and ketotriasidase in 430 patients, 264 controls. We found that sorry. I have to go back. Yes. We found serum ketotriasidase levels 6 times higher than in healthy controls in active sarcoidosis. Then we also found the correlation with radiographic stage of the lung disease. This is the ROC analysis, pronouncing the specificity of 70% to exclude the specificity, and the sensitivity of 82.5% to confirm active sarcoidosis. And it doesn't work, this one. And the sensitivity of serum AC was 66%, the specificity only 54. The disease duration was also in correlation with serum levels of ketotriasidase. Vitamin D activity, we also did the research on vitamin D activity in sarcoidosis, and it is known that symptoms of vitamin D deficiency resemble many of the systemic manifestations of sarcoidosis. These are some benefits of vitamin D, and this is our analysis. On 400 patients, we found statistically significant correlation between patients with chronic sarcoidosis and low levels of serum vitamin D. We also performed the PET scan exams in our patients. We published the data in Clinics Nuclear Medicine 5 years ago. This is an example of our patient. I cannot use this pointer, unfortunately, but you probably see. I always miss the point. You probably see at the picture A the multiple size of increased uptake of 18F-FDG, and later on during the treatment no evidence of FDG uptake. And the results published in this work suggest that 18F-FDG, the PET scan, may be valuable adjunct to clinical evaluation, and we actually use this PET-CT in order to verify a different organ involvement in sarcoidosis. It also shows the results of PET scan, significant correlation with biomarker, serum hetotriositase activity, and what we did not expect, but found that it is in tune with different symptoms, correlation significant with fatigue, cough, chest pain, and even bone pain. We examined the quality of life in our patients, mostly pointing out the fatigue. This is the analysis I speak about on the CHEST conference 10 years ago. 168 patients with fatigue, or most of them with pulmonary and acute sarcoidosis, statistically significant correlation with fatigue. Fatigue scale we have also in Serbian version on ILD Care Foundation site, and it is automatically counted the scores, both mental and physical. This is how it originally looks like. Nowadays we got years ago permission to use King Sarcoidosis questionnaire from Surinder Beerings, and it was published in Thorax. Let me finish. Okay, and these are our results. About the therapy, we started using methotrexate in the treatment of sarcoidosis almost 20 years ago. And these are our publications trying to find the genetic network among sarcoidosis patients. We did the genetic investigation with Freiburg University, Germany, published our data in ERS journal, and we are close to the Hippocrates thoughts about personalized personalized medicine and the importance of knowing what sort of a person has a disease than to know what sort of a disease a person has. And I wish you very happy and successful for coming New Year. Thank you for your time.
Thanks a lot, Professor Violet. You are welcome to our Congress. Please, I want to ask you a short question. How prevalent is sarcoidosis in your locality? And what about the outcome of treatment? The best line of treatment you have tried, and what's the best line of treatment?
Well, the incidence of sarcoidosis in Serbia, I missed that slide just for the sake of time, but it is a very high incidence because we have a huge database of more than 2,000 persons, and counting on the overall inhabitants in Serbia, which is about 6 million, then it seems somewhere about 70 per 100,000 persons. About the treatment, we started, steroids, we all know, are the first line of treatment. Second line, we use cytotherapy like methotrexate most in our country, as far as I know, in North America as well. And the third line, cytokine modulators like infliximab, for example, and anti-TNF drugs. My experience is broad with the treatment of sarcoidosis with methotrexate. We presented on chest about 139 patients, but that was 10 years ago. Nowadays, I have more than 250 patients treated on methotrexate, no side effects, no toxicity.
Thanks a lot, Professor Violet.
Thank you.
Yeah, thank you. بكرر شكري الحقيقه للجنه المنظمه لاختيار السبجكت الرائعه الحقيقه الاستاذ الدكتور طارق بيه صفوت والدكتور جمال وجميع افراد اللجنه المنظمه. وبشرف نشير ذيس سيشن مع الاثنين من متميزات علما وخلقا الاستاذ الدكتوره ايه والاستاذ الدكتور جيان. وبندعو النكست سبيكر بروفيسور برانسلفا ميلكوفيتش. She will speak about systemic biomarkers in the evaluation and management of COPD patients.
Is this working? Dear chair ladies, dear colleagues, it's a privilege for me to present the results of studies about biomarkers in COPD, and I would first like to thank to the organizers who invited the Respiratory Society of Serbia and to present our results. So this is the content of presentation. I will start that this diagnosis of all diseases, but also COPD, has changed in time. Maybe it will be changed in next years in more molecular level. We should see. So do we have a good biomarkers in airway diseases? For COPD, we have only alpha-1 antitrypsin as a good biomarker and also CT scan for emphysema. But we miss a lot of data about biomarkers. There is a lot of literature, but we miss a point about it. We can get samples for biomarker studies from different parts of respiratory system. Some of these analyses are very invasive, and we should start with non-invasive, as you know. We can analyze biomarkers that reflect pathological processes, inflammatory processes, and oxidative process. So when we are talking about biomarkers in stable COPD, we already know that CRP, high-sensitive CRP, is a very good biomarker of prognosis of COPD, and there is a difference. Sorry, but I could not show it. The level of CRP in patients with stable COPD is higher than not only healthy control, but also compared to smokers. Also is established for fibrinogen, and there is something I would also like to stress, that the patients, as you can see on this slide, with higher level of serum fibrinogen in stable phase of disease have a worse prognosis and higher mortality. When we are talking about NO in exhaled air, we have different data. On this slide, you can see different results of two studies, so we cannot rely on the data of NO, because there is very high within patient variability, and we still do not have enough data about NO in COPD. When we are talking about IL-6, in a Spanish study, EPISCAN study, it's shown that the level of IL-6 is increased in the patient with stable COPD compared to healthy controls, and something also that the level of IL-6 is higher in COPD exacerbation than in a stable phase. When we talk about matrix metalloproteinases, the level of MMP9 is higher in COPD patients, and also MMP12 in sputum, induced sputum, is higher in COPD patients than healthy controls and smokers. And something else, it was analyzed in other study. I will just remind you about the ECLIPSE study. It was a study that analyzed the patient in stable COPD, and the primary aim was to find the main point of frequent exacerbators. But also in this study, the authors analyzed inflammatory biomarkers. And what about clara cell protein 16? We know that it's a biomarker of dysfunction of epithelial cells, but also its expression is reduced in COPD. When we analyze the level of serum CC16, we can see the level of this biomarker is higher in COPD patients. And also, it's very high in a patient with advanced COPD according to the GOLD stages, parametry stages. What about surfactant protein D? It is marker of multiple components of COPD, but you can see on this slide the level of SPD is higher than in COPD stable patients than in control, and especially in a GOLD stage 4. And there is a very good response of the level of SPD in patients who are treating with prednisolone. What about the others? There is a lot of studies, a lot of biomarkers. I will just tell you that IL-8 is also elevated in patients with COPD. IL-18 is elevated, but especially in a GOLD 3 and 4. And also IL-32 its level is increased in alveolar macrophages in patients with COPD compared to non-smokers. These are studies, I don't want to confuse you, just to tell you that a lot of studies analyze correlation between biomarkers and the correlation to FEV1 and decline of pulmonary function. So you can see a lot of data about, but we cannot rely on this data in our practice. But we know also that the number of sputum neutrophil in patients' serum correlates very well with decline in lung function, and also interleukin-4. And now something about biomarkers in COPD exacerbation. These are results of our study that when we analyzed the inflammatory status and oxidative status in the patients who were hospitalized in a clinic because of severe COPD exacerbation, and it was admission on first visit, admission to hospital, and the second one, the discharge. So on this slide, I showed in a purple line, total antioxidative status was different in patients, COPD patients compared to healthy controls, not only on admission but also on discharge. And we found something also, paraoxonase activity, which is antioxidant enzyme, was especially decreased in a patient who had also coronary artery disease. It maybe reflects the oxidative stress, not only in COPD, but also in coronary disease, which is very common comorbidity of COPD. Our clinic was a part of international study. The name was PROMISE study. It lasts 3 years, and the patients with stable COPD were analyzed every 6 months, and also on exacerbation. And you can see the demographic and pulmonary function about these patients, but I will just show you the main results. We analyzed the circulating proadrenomedulin, and we have found that the level of proadrenomedulin is a very good marker of severe exacerbation, predicting severe exacerbation. But also, we found that it is very good as a part of BODE index, and we suggested BODE A index. A is a level of proadrenomedulin. It's a better predictor of mortality in COPD than just BODE index. And that's what I told you. And we also published the level the results of analyzing the level of collagen elastin turnover, which is much higher in patients with COPD compared to the patients to healthy controls. And just to remind you that we have some biomarkers that could predict the exacerbation. We were talking about CRP, and maybe just to remind you, the level of troponin predicts long-term mortality in the patients who are frequent COPD exacerbations because of comorbidity and, of course, the reflection of COPD on cardiovascular function. And what about blood eosinophils? It's very common to talk about today, but I will just show you studies that were the main studies that influenced new GOLD strategy update. So this is a study that showed analysis of the results from forward study and Dransfield studies, and red color are the patients who were treated only with formoterol, and blue were treated with budesonide and formoterol, beclomethasone and formoterol also. You can see in both studies that if the level of eosinophil is higher, the risk of exacerbation is increasing if the patients were treated only with bronchodilators. So if they were treated with vilanterol and fluticasone furoate, the risk of exacerbation was lower than if they were treated only with bronchodilator. And also analysis of forward study was shown when it was analyzed quality of life using St. George Respiratory Questionnaire, that the quality of life was also better if the patient had a higher level of eosinophils and if they were treated with ICS and bronchodilator. So this is the second very important analysis that influenced the GOLD strategy, that shows that if we divide patients in two groups, eosinophil counts less than 2% and higher than 2%, that there was a better response time to the first moderate to severe exacerbation was reduced if the patients were treated not only with bronchodilators but also with inhaled corticosteroids. And also that is something that influenced, and the other studies, I will just skip this one because a lot of studies, and you know that there is a different cutoff in different studies for level of eosinophils, but in last COPD guideline, gold guideline, which was published near 1 month ago, there was a line between 1% of eosinophils and more than 100 and more than 100 eosinophils. So according to the published studies, different studies, it is recommended not to introduce ICS to the patients who have COPD but do not have a number of eosinophils less than 100. And if it is higher than 100, we should consider to introduce this treatment. So just about some conclusions, that biomarkers should be assessed in COPD patients, but we need more data from different studies, just trying to find a correlation between COPD severity and the best biomarker. For my opinion, we shall not get enough data only from number of eosinophils. So I just wanted to thank you for your attention.
Thank you, Professor Melenkov, for your nice presentation, and allow me to thank the Bronchology Society Board for her invitation for this well-organized conference. The second speaker will be Professor Spasuji Popovic, who will talk about the role of rigid bronchoscopy and electricity in interventional pulmonology.
First, I would like to thank my dear friends from Egypt. I'm glad and honored to be here again. And things I'm going to speak about today are how do we actually combine things in interventional pulmonology, and how do we do that in order to achieve something better for our patient. Well, from the start, actually, bronchoscopy was interventional. First, bronchoscopy was not done because of the diagnosis, it was done because of the treatment. And now no one remembers this guy. His name was Horace Green. And in 1898, he actually did something that nobody did before him. He entered the airway with a gum catheter and showed that people can actually survive that, and there are no serious consequences of that. For this time, it was a taboo. When Green presented his technique to the American Surgical Society of New York in 1847, he was expelled from the society. They told him, this is an anatomical impossibility and unwarranted innovation in practical medicine. He was expelled from the society and he was forgot. In 1897, Gustav Kilian did the same thing. Actually, he did that thing by mistake. He tried to remove foreign body from the esophagus and enter the trachea. And the new branch of medicine, of pulmonary medicine, was born. And now we'll see Professor Kilian's settings. What do we have here? Practically, we have here the same elements as we have now in our bronchoscopy units. We have the doctor, we have the patient. Okay, anesthesia was with cocaine in that time. And we have assistant who is pumping air in the patient's lungs. And we have a big, strong nurse to hold the patient because there was no general anesthesia for bronchoscopy at that time. Except our nurses are now thinner, nothing much really has changed. Actually, actually revolution is taking place in the field of bronchoscopy right now. Bronchoscopists have many different tools to assess the airways, and every tool is promising to be better than the previous, and mortality rate is still below 0.1%. So where is the limit? What are the goals of interventional procedure? Just a quick reminder. We need to reopen obstructed airway, to maintain its patency, and to treat symptoms. There are many causes of central airway obstruction, and in our practice, we are mostly dealing with malignant ones, but also non-malignant can be exceptionally dangerous. I always say the benign stenosis of trachea is not a malignant disease, but the position is malignant itself. Well, we can much easily solve fixed stenosis than dynamic stenosis. In dynamic stenosis, there is really not much that bronchoscopists can do. And how do we do it? By using all these interventional procedures, fast and slow. When we need emergency debulking, we use mechanical debulking, laser, electrocautery, argon plasma coagulation, and finally we place stent, or sometimes we place stent in the beginning of the intervention. The combination is the thing which is actually important. And especially in these cases, when we are treating central carina, it is very hard to do proper interventional procedure, and it's sometimes very hard for patient to survive this procedure. So we have to be very cautious when we are dealing with the central carina, just a short notice. These techniques can be divided into 4 groups. First, techniques enabling rapid removal of obstruction in a case of life-threatening obstruction. Techniques enabling delayed removal of obstruction in case of non-critical stenosis, and techniques that enable maintenance of airway patency. And there is a group of techniques also which are enabling symptom control, such as hemoptysis, argon plasma coagulation, electrocautery, and laser. But we should all stick to this. We need to thoroughly evaluate the patient, to plan the strategy, to use all techniques to assess the results, and which is the most important thing, to have exit strategy. What are we going to do with the patient, how the patient will feel after the bronchoscopy, after our intervention. So as you can see, most of the things in bronchoscopy actually happen before the bronchoscopy in your head, in your mind. I will show you a few cases to illustrate this. First, there is a white young male, 25-year-old. He had subdural hematoma and cerebral contusion and blindness as a result of occipital lobe injury. Also, he was intubated for a very long time, and because we actually thought that he is not going to survive this, we put tracheostomy and percutaneous gastrostomy in the emergency trauma unit. But patient survived. And on the June after 1 month of cannula present in his trachea, tracheostomy was closed, gastrostomy was closed, but the patient developed 2 days after that stridor and hoarseness. Flexible bronchoscopy revealed post-intubation tracheal stenosis and post-tracheostomy tracheal stenosis. And we decided to plan the strategies to start with rigid bronchoscopy first, to open the airway, and then to decide what to do. Either we can place a stent, which is not recommendable in this situation, but there are some factors which were actually endangering the patients more than bronchoscopy itself. It's an unstable tracheal wall. Why? There was a hole in the anterior tracheal wall. So it can represent a problem. This wall is not stable to do 100% recanalization. And the tracheostomy was closed like maybe 10 days before our bronchoscopy. And what did we decide to do? This is recanalization with 6.5 rigid bronchoscope. Mechanical recanalization, you see diaphragmal stenosis. And after that, and below the stenosis, actually the bronchus, the bronchial tree is normal. Below the stenosis, you see we passed the stenosis. Then I decided to consecutively dilate this stenosis in this patient with, to dilate this stenosis with 7.5 rigid bronchoscope. It's not working, okay? And decided to stop. Why? Because in this situation, there is a danger of collapse of whole trachea. You need some stenosis to stay in the trachea in order not to make tracheomalacia to the patient. So collapsible trachea is actually more dangerous than the trachea itself, stenotic trachea. Now what are we going to do with this patient? We expected improvement, but improvement didn't happen. Why? Patient had hoarseness still, patient had still high airway obstruction, and we decided to do flexible bronchoscopy, and the reason was bilateral vocal cord paralysis. Patient had two diseases, post-intubation tracheal stenosis and vocal cord paralysis. So, what is the point of this case? First, unstable anterior tracheal wall, you don't recanalize stenosis 100%. Second, beware of this. First bronchoscopy in this patient should be taken with conscious patients with spontaneous breathing in conscious sedation. The patient should breathe spontaneously, not in general anesthesia. We performed all procedures in this patient in general anesthesia, and we didn't see the movement of the vocal cords. And of course, we should always combine rigid and flexible bronchoscope when we use it. In this case, patient with advanced adenocarcinoma, EGFR negative, developed dyspnea and stridor. We have tumor arising from right upper lobe, obstructing right main bronchus, and we decided to proceed with rigid bronchoscopy with mechanical resection and to stop the bleeding with argon plasma coagulation. It looked like this. Here is the process. I don't see this video. Maybe I should click here. Here is how it works. You see the residual lumen inside the main bronchus. Then put the rigid bronchoscope inside, and with the shaft of the rigid bronchoscope, you should core the tissue. And we removed with cryoprobe this tumor. And after the intervention, actually, the right main bronchus was free, and we performed argon plasma coagulation to stop the bleeding from this side. So we always combine. And in post-procedure, you see this patent right, this is left main bronchus, you see patent right main bronchus and only obstructed right upper lobe bronchus, which is insignificant for this patient for ventilation. But we also decided to take rebiopsy in this patient. Why? Because adenocarcinoma can change during time. And this patient from EGFR negative became EGFR positive, and he was now for tyrosine kinase inhibitor treatment, and he's still alive, thanks to rebiopsy. So you should always consider that when you are doing control bronchoscopies and mechanical, always take the tissue. Always take the tissue. Maybe tumor change its nature. And this is how we do it. We start by recognizing the anatomy of the lesion and a potential residual lumen within the affected bronchus. We need to coagulate with contact electrocautery, and then try to mechanically debulk the tumor either with the shaft of the bronchoscope or with the cryoprobe. And after that, we may or may not consider the stent placement to maintain airway patency. We can achieve success in different levels, but we all know this. Technically, most of us can do that. Can we improve symptoms, spirometry, quality of life? Yes. When we can do it during the procedure, during the course of the disease, we can do it always in neoadjuvant, adjuvant setting, preoperative setting. We can always do interventional procedure. But now we are aiming for this last thing. Is there a survival benefit? Can patients live actually longer when we do the interventional procedures? And yes. And there are data from 1980s showing that while there was no stent available, you can prolong the life of stage 4 patient by using interventional procedures. And this is the last study in 2017 that showed that practically if you have two groups of patients, one with central airway obstruction and others with without central airway obstruction, those with central airway obstruction will live shorter. But if you apply interventional procedure, they will actually live as long as those without central airway obstruction. That is also a very important thing to remember. And this is a slide I always put. I can do it does not necessarily mean I should do it. There are dangers, and the burden of decision and responsibility is always on bronchoscopist. You decide. And in these cases, you never do interventional procedure because there is no benefit for the patient or for the patient's ventilation. No effect on quality of life. So it comes to these questions. Is it possible? Is it urgent? Can I wait? Can I do it? Just one more minute and I'm finishing. Can I wait? Can I do it? Is it going to work for the patient? And can I do it with equipment and experience I have? Now, you see these snakes. Why are they so dangerous? Doing interventional procedures without proper training is like putting your hand in a box full of snakes and hoping that the snake who will eventually bite you will not be the poisonous one. That is very important to know. Without proper training, don't try to use interventional procedure. I always say, rigid bronchoscope is not a tool, it's a weapon. Depends how you use it. We always have this algorithm for an endoscopic management of central airway obstruction, but this algorithm will tell you how to do something. It will not tell you what will be the result of your procedure. You have to judge by yourself. So be moderate. Recanalize just enough to restore airway patency with technique you are most familiar with. You obtained argon 1 month ago. You don't have proper training. There is a patient. You have to do interventional procedure, but you are not skilled with argon. Don't do it. If you have rigid, only do it with rigid. If you have stent, only do it with stent. Don't try to combine if you don't know the procedure. And very important thing, we have to move from I do it and experiential knowledge to systematic evidence-based patient-oriented approach. And that is the true paradigm shift in interventional pulmonology. I would just like to remind you that next year there is a Congress for Bronchology and Interventional Pulmonology in Dubrovnik in May 2019, and also there is a Congress in Beijing in 2020 of World Association of Bronchology and Interventional Pulmonology, and I would like to thank you for your attention.
Thank you very much, Dr. ESSB, for this very nice presentation. We are here familiar very long time ago in the Ain Shams University, University Faculty of Medicine. We have the Egyptian Bronchology, part from our, from other society of the Egyptian Society of CT and Tuberculosis. Now we are going to introduce Professor Sophia Glumak, molecular testing in era of personalized therapy of lung cancer. This is your first time also to become in Egypt?
Yes, it is.
Welcome, welcome, welcome to Egypt.
Much.
We are very happy to receive you here. Please introduce your lecture.
Dear chairmen, dear colleagues, thank you very much for the invitation to participate in this meeting. Precision medicine and personalized therapy in lung cancer is a more recent development, but it has been developed into an extremely diverse and complex branch of oncology, bringing the benefit for some kind of patients, multiple choices for the oncologist, and considerable demand on pathologists. The pathological and molecular classification of lung cancer has become substantially more complex over the past decade. Simply distinction between non-small cell and small cell morphology was sufficient to guide systemic therapy. Non-small cell lung cancer can be further divided based on morphology and immunohistochemistry into adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and some other rare variants. But the classification does not end here. And pathologists have known for a very long time how different individual tumors can be from each other. And to a large extent, we now understand that these morphological variations are a reflection of the molecular heterogeneity. The specific molecular alterations that drives tumor growth and provide targets for therapy have been best defined in adenocarcinoma. And the most useful biomarkers that can predict the efficacy of targeted therapy are called driver mutations. There is increased interest in the molecular landscape of squamous cell carcinoma, highlighting the potential new therapeutic targets. As you can see, there are a lot of potential biomarkers that can be added to next algorithm for testing in those patients. What is a biomarker? Biomarker is a characteristic that can be measured and then evaluated as an indicator of normal, biological, or pathogenic processes, or as a pharmacological responses to some intervention. Biomarkers encompasses a wide range of molecules. And we also have a cancer biomarker. Cancer biomarkers are molecules produced either by tumor cells or by some other cells that persist in body in response to the tumor. Cancer biomarker can have some different, can be applied in a different situation, and one of them is for selecting the patient who will respond to a specific kind of therapy. The pace of discovery of molecular drivers and development of corresponding therapeutic agents is accelerating. And in order to assure that the clinicians stay abreast of development in this area, medical society have developed standards for molecular testing. At the end of January, three leading medical societies have updated their guidelines for 2013, and those was the guidelines evidence-based for molecular testing of lung cancer. In these updated guidelines, they have reaffirmed the majority of recommendations, but also they refer to 5 specific topics. First of all, what new genes should be tested in lung cancer patients, and what methods should be used in order to do that. They answer the question, is molecular testing appropriate for lung cancer that do not have an adenocarcinoma component? And what should we test with patients who relapse on targeted therapy? Also, they introduced a liquid biopsy as a new sample for molecular testing. Immunomodulatory therapy was not the subject of these guidelines, but expert consensus opinion was issued, an opinion regarding the use of biomarker in order to select the patients for those kind of therapy. This guideline know for 3 categories of biomarkers. The first one we must test, the second one we should test, and we have an investigational one, and those are not recommended for the routine practice. What do we already knew? We knew that physicians should use molecular testing to guide initial therapy, and we knew that we don't use FISH or TISH to detect EGFR mutation. But what if we have a patient in the early stage of the disease? The opinion is that we should test, but the decision to do so should be made locally by each laboratory and, of course, with collaboration with this multidisciplinary oncology team. There is still strong recommendation about molecular testing for EGFR and ALK for all adenocarcinoma patients, and the samples suitable for those molecular analyses are paraffin blocks and cytological preparations. Of course, we should employ assays sensitive to able to detect the mutation in a specimen with as little as 20% of cancer cells. And still there is strong recommendation against, please remember, against immunohistochemical testing in order to select patients for TKI therapy. And now what's new? Which new genes should be tested for lung cancer patients? This updated guideline strongly recommend adding ROS1 fusion detection to ALK and EGFR testing. The genes such as BRAF, RET, HER2, KRAS, and MET is currently not indicated as a routine standalone assay. However, it is appropriate to include them as a part of larger testing panel, either initially or when routine EGFR, ALK, and ROS testing results are negative. What method should we perform in order to do all those testing? Immunohistochemistry is accepted for ROS1, but only as a screening tool. If we have a positive result, we should confirm them by some molecular or cytogenetic method. But for ALK, immunohistochemistry is acceptable, and only if we use appropriate clone. This is Ventanan's clones. Multiplex genetic sequences panel are preferred over single gene tests to identify other treatment options beyond EGFR, ALK, and ROS1. Here we have to be careful about the language. The term recommend or prefer does not mean not use single gene assay test. There is no evidence that NGS is better analytically. The single gene assay tests are still acceptable. The reasons for preferring NGS is largely operational, because NGS is a method that can generate a full breadth of alteration needed in a smaller sample and in a shorter time. This means that NGS can spare patients of additional invasive procedures and can reduce time to treatment. Is molecular testing appropriate for lung cancer that do not have an adenocarcinoma component? Yes. Yes, but when clinical characteristics suggest that there is a high risk of targetable mutation, or if we made diagnosis on a small sample, on a small biopsy, and usually we did, and for that reason we can't for sure to exclude the presence of adenosquamous carcinomas. If you have patients who relapse on targeted therapy, the updated guidelines strongly recommends to test EGFR mutation called T79M. And in order to do that, we have to use a very sensitive assay that should detect mutation in samples with at least 5% of tumor cells. In cases that we don't have enough tissue for molecular analysis, the updated guidelines suggest that recommends to use cell-free DNA or a liquid biopsy. But if we have a negative result for mutation T79, we should examine the tissue sample as well. Liquid biopsy is gaining popularity as it provides an opportunity to genotype in less invasive or in less expensive manner. And here you can see the list of emerging markers for molecular testing in lung cancer. And for some of these mutations, there are targeted therapies in the United States. Regarding the immunotherapy, opinion is that samples should be preserved for assessment of biomarkers that can predict the response to this kind of therapy, such as PD and PD-L1. And for now, there is no recommendation regarding the testing methods. For the now being, we are using immunohistochemistry, and you can see that we have a lot of clones, and each clone is connected to a specific therapy, and each clone have its own cutoff, so it's not so easy to decide which one we should use. This is a summary of recommended biomarker tests. We must test PD-L1, EGFR, ALK, and ROS1. And according to the American Society of Clinical Oncology, we should add BRAF to this must-test panel biomarkers. The second panel is RET, HER2, KRAS, and MET. Ideally, should be done with a single multiplex test to save time and tissue. And what's next in the molecular testing? Tumor mutational burden, microsatellite instability, or something else. We all know that tumor mutational burden is a number of non-synonym mutations. And it is well documented that tumors with a high TMB have an increased number of neoantigens and have better response to inhibitors of immunological checkpoints. Microsatellite instability, high microsatellite instability or deficiency mismatch repair are biomarkers predictive for response to immunotherapy that is independent of the tumor histology and fully dependent of tumor's genetic compositions. Biomarkers and molecular medicine are replacing the traditional medicine one size fits for all. The essence of the precision oncology lies in the use of biomarkers. And with the rapid advances in the cancer biology, it is not unrealistic to expect that this current algorithm will be revised soon as well. So we have to be able to respond to new demands. Thank you very much for the attention.
Thanks a lot, Professor Sofia, for this elegant presentation. And before closing this session, Bronchology Society and on the top of it, Professor Tariq Safwat and Professor Gamal Rabi want to express their gratitude and thanks for your presence. And they will give a sample of society for you and for other elegant speakers in this session. We will start with Professor Violet.
عمرة يا جميل عمرة برضه يا دكتور طارق
You can, Dr. Mustafa, you can. The second, next speaker, Professor Pranselva.
Attention, my judge. Next, Professor Spagio Popovich. Spagio. سلم من بعيد ده، سلم من بعيد. اوكي اوكي. Now, the last but not the least, Professor Sophia Glomek.
Thank you very much. Please, professors of Serbia, can we have a photo with us? Yes, please, because this is your first time of Egypt, and we're very welcome to speak. Yes, all of you, all the Serbian professor, please come to the stage to have a collective photo with the Egyptian Society of Bronchology.